Yes, sir.
And make your, yeah. Have you shared the screen before?
Yes.
Do you know how to share the screen?
Yes.
Okay.
Just hold for 1 minute.
Yeah.
Nathu sir, please start. Thank you.
Yes. So good evening, one and all, to this second new initiative from Maha IIP. So in this initiative, Maharashtra State IIP is coordinating with IIP Pune branch, and a special activity for postgraduates is being started, because this was one area where Maharashtra State IIP was not doing a lot many things. So Honorable Dr. Sanjeev Joshi sir had thought that we should be doing something for the PGs who are studying pediatrics in the state of Maharashtra and all over the countryside. So we are starting this Maha IIP case forum. So the plan for this case forum is going to be, there would be a case presentation by one of the postgraduates in either a DNB institute or a medical college. And this will happen once in every month. The cases will be of different systems, and the examiners will also be from all across the state of Maharashtra. And of course, the additional incentive for this IIP case forum, Maha IIP case forum, is also going to be inclusion of OSCE, which is a very integral part of the DNB examination in pediatrics. So in each episode, we will be having a few OSCE spots which will be displayed, and the experts will give the answers for those OSCEs. So for today, this is the first session, and I welcome Dr. Sachin Patil, who is my scientific co-coordinator from Maha IIP. I'll be also welcoming Dr. Shushruta Deshmukh. She is the IIP Pune PG coordinator, and she has been running the IIP Pune PG program since last 3-4 years very consistently and very regularly. Dr. Shushruta, are you there? So Dr. Shushruta will be joining shortly.
She is there already.
I'm there.
No, she had joined, sir. She had joined.
Yeah,
She's there.
Yeah, so please make Dr. Shushruta co-host. Shushruta, you can take over, start sharing the screen, and you can introduce today's topic.
Okay, I'll start right away.
Yes, once you start sharing the screen.
Okay. Yeah, so basically today's case is going to be presented by Dr. Shravani Kulkarni. We have a neuro case. They are 3 from Jahangir Hospital and third year DNB student, and she's going to be examined by our very capable examiners, Dr. Uday Satara and Dr. Abhijit Botre, who is a pediatric neurologist, a lot of hospitals, primarily being KEM in Amdar and Jahangir. Shravani is ably mentored by Dr. Sagar Lat today, who is a senior consultant pediatrician, as well as Dr. Raj Ganacharya, both of them being from Jahangir Hospital. So we will have this case presentation by Shravani, but it will be preceded by OSCE session. Since this is the first time, we are just having a very short OSCE of 3 questions. So it's for all the participants to understand the question and answer it on their own, not in the chat box, but we'll give you some time, and then the answers will be discussed by Dr. Abhijit Bhutri. So Sanjay, if I can start screen sharing, is it fine?
Yes, and it is okay if the participants put the answers in the chat box also. That is just an exercise for them. There should not be any problem.
Okay.
Are you able to share the screen?
Yeah, I'll just see. Sorry, if somebody else can share the screen.
No, ma'am, you have a right. Just click on the share button.
No, I did. Yeah, I clicked on the share button.
Yeah, it is opening. It is opening.
It is opening.
Yeah. We can see your desktop.
PPT which you are showing.
I can
This
just
is a blank PPT.
yeah, it's a blank. Just give me a minute.
Shall I say yes from my end?
Just give me a minute. I'll just see whether. Otherwise, I'll see it. Yeah, is it visible now?
No.
Okay. Okay. Okay, I think now it is visible.
Yes, it is visible now. Go back to the first slide.
Yeah, so this is the first slide. I'm really sorry for this error. Okay, so we begin with the first question here. This is a case of a 12-day-old neonate boy who came with 1 day history of lethargy, refusal to feed and vomiting. Antenatal course was absolutely normal. Baby was born at home and was never shown to any hospital. And the child was only on breastfeeding. On examination, the child appeared very dull, lethargic. He had a heart rate of 140 per minute, a respiratory rate of 56 per minute. The child was severely pale. He had febrile, he had very feeble peripheral pulses and low BP. However, the anterior fontanelle was full. The child was moving, but the child had a very weak cry on pain and stimulation. And the umbilical stump was found to be clean. This was the scan which was shown. The scan was done which revealed this picture. So the first question is, what is this condition? What investigation would you do to diagnose it? Investigation to know the extent. Where do you think that the things went wrong here for the child to land up in such a situation? And what are the other conditions which caused this? So we give you 2-3 minutes to answer the
You
question.
can show the scan again, Shushruta.
Oh, yeah. So this is the CT brain.
I think we can start discussing the case.
Yeah, so Dr. Abhijit, if you can go ahead with the discussion.
Yeah, I think PGs are all tuned up with the case. So here I would like to highlight here is he's a male child, normal antenatal at home delivery, never shown to hospital, and now came with a shock and severe pallor. So usually what is the thing which runs in our mind is, that's the reason I put the CT first. So what exactly? So what run in our mind is sepsis, but mainly there are septic mimickers, and there is not actually the kind of a setting of the sepsis. So what we see on the scan, ma'am, can you go back on the scan? So this is CT brain, which showed the intraventricular hyperintensity, which kind of says this intraventricular hemorrhage, and there is compensatory obstructive hydrocephalus, which you are seeing with huge dilated occipital horn. Of course, we don't have the multiple images, so we don't say it's really obstructive or communicating hydrocephalus. Next slide. Yeah. So what is the investigation to diagnose? So basically what happens in us, because we kind of a couple of us are in the resource poor setting and the baby patient is sick, kind of taking the baby to the scan and all these things becomes really difficult. So what is the investigation of choice here? Anybody? Before that, which has little therapeutic effect? So we do PT-PTTK and we send vitamin K degradation products. So now we have this diagnosis of late hemorrhagic or early hemorrhagic disorder of the newborn because of vitamin K deficiency. And the emphasis was given, the patient was born at house, so probably never shown to hospital, so vitamin K was not given. And umbilical stump was clean, so then we rule out the sepsis. The investigation to know the extent, as we did, was CT brain. Ma'am, you can go to next slide. The answers are there, so it will be easy for them to even assimilate the answers.
You all can put the answers in the chat box also.
Okay. Now you can
No,
go to next
Shushuda, you
slide.
can
So
show the next show
next
the
slide.
answers.
Okay, okay. So basically, this was the condition, like he said, was delayed hemorrhagic disease of the newborn causing an intraventricular hemorrhage and a hydrocephalus. The investigation required here would have been PT of PIVKA, that is protein induced in vitamin K deficiency, vitamin K absence. Investigation to know the extent would be a bedside USG or an MRI brain if it was possible to transport the child there. What things went wrong? Well, like he said, it was a home delivery and hence vitamin K may not have given and hence the child must have bled. And other conditions which caused this were cholestatic jaundice, where again vitamin K would be low, prolonged antibiotics, the same mechanism, or to rule out a bleeding disorder like a factor deficiency. So Abhijit,
exactly. So your clinical scenario may differ. So cholestatic would have present little late, prolonged antibiotics and bleeding little because it's a male child. That is the reason we again need to ask the umbilical stump and other things. So other factor deficiency can give rise to bleeding disorder like hemophilia and etc.
I just want to tell here, if the PT and PTTK is normal, in this case, the PUCA comes into the picture, that is protein-induced vitamin K absence. So that will rule out vitamin K deficiency.
Very true. So the emphasis here is like get a sample drawn and give vitamin K. Don't wait because then the patient will deteriorate much more. Yeah, that way.
Okay, so I will go to the next question. So this is a case of a 1-year-old, 2-month-old boy who presented with flexor infantile spasms since the last 2 months. Again, this child had a normal ANC and a PNC course. However, the child had developmental delay. Head circumference was normal, no microcephaly here, and normal motor examination. This was a picture of a general examination where you see distinct lesions on the skin, and this was the MRI brain flare image. Now, what is highlighted in the picture? So, what is highlighted in this picture is what is meant here. Which disorder is associated with the same? What is the mode of inheritance? And what are the other associations, skin and systemic, with the same? So, I go back to this picture here. So, name the lesion, name the condition, name the inheritance, and other associated things which you can find with this condition.
So exactly, I think the people are guessing it right. So what we are seeing is hypopigmented skin lesion, which probably, if at all they are hypopigmented, you can confirm with Woodlam's examination. So here what we see is the ash leaf macules, which are there scattered in the body. The disorder associated with this is a tuberous sclerosis. The mode of inheritance is autosomal dominant, but make it sure your whole exome may not sometime pick it. You need to do a deletion duplication test. So this is one of the caveats of doing whole exome. You may not pick it if there is like small deletion and duplication. And what are the other skin conditions, systemic condition? You have adenoma sebaceum, which comes later in the adolescence stage. You can chagrin patch, which is like, kind of like a orange skin, which is on the lumbosacral area. You have cardiac rhabdomyoma, and you have renal angiolipomas, and sometimes you can have retinal hematomas. Yeah, and this is one of the neurocutaneous syndrome.
Yeah, and the additional features, Abhijit, can you tell
Yeah,
me?
and the MRI, what you see is what you saw. Can you just go back on the image?
Yeah.
So here what you see the cortical tumors, so those are kind of flare images which are mushroom shaped with a broad kind of on the periphery and thin base. Sometimes they're calcified. What you can see is at times is the subependymal nodules. So these are kind of heterotropias, which are the gray matter around the ventricle lining. And later you can see a sega, which is subependymal giant astrocytoma. Yeah. And you can get some scattered white matter abnormalities as well. True. And anybody which is drug of choice for this? Those spasms? So vigabatrin. So vigabatrin is drug of choice for those spasms. So yeah, exactly, very well. So vigabatrin is drug of choice which can be helped in those kind of spasms. Yeah. So usually conventional anti-seizure medication may not work. Yeah.
Okay, so moving ahead with the last one today. This is a 13-year-old girl. She was absolutely normal since birth, and her developmental history is also normal. She's very good at school, bright at school. She had one first unprovoked motor GTC in the morning, lasting for 3 minutes, with incontinence and tongue bite. And on inquiry, it was found that she had several early morning jerks where she would keep on dropping objects which were held in her hand. So a 13-year-old bright child, normal developmental history with one GTC followed by several early morning jerks. So which test would you advise? So obviously one EEG sleep awake EEG was done, which showed generalized epileptic discharges and poly spikes. So the questions here are: what is the epilepsy syndrome we are dealing with? What are those jerks which were mentioned, multiple jerks which she had on getting up in the morning? Would any further investigations be required, and if so, which ones? What will be the drug of choice, and which medicine would you specifically avoid in order to so that you're preventing the worsening of the condition? So again, going back to the EG.
So yeah, very well. So I think, I mean, the audience is pretty good. So what we are seeing here is basically I would like to emphasize you need to get a HV14 during this thing, because there's the activation procedure. So we get a signature on this JME, which is juvenile myoclonic epilepsy. What we get is there is some photo kind of a convulsive photoelectric response where you get multiple polyspike, generalized spike wave discharge, and you can get fragmented, I mean, 4 to 5 head spike and wave discharge as well. So typically, an adolescent girl with normal intellect having those jerks in the morning and one GTCS, usually the GTCS would happen sleep deprived. So the jerks were a myoclonic jerk, and that time you need to typically ask, they will tend to drop the things from them. Any further investigation needed? Absolutely no, unless the things are okay. But again, mind you well, because your progressive myoclonic epilepsy may tend to worsen, and if at all you find any kind of thing which is worsening, so for example, the intellect, the seizures are increasing, is not responsive to treatment, definitely you need to kind of further investigation. But classical JM, you need not to plan any investigation, not even MRI. Drug of choice is valproate, but again, there is like some plus minus, but textbooks wise is valproate, because adolescent girl we tend to kind of avoid. But make you sure even a small dose of valproate will kind of stabilize them. And the medicine we should avoid is a carbamazepine. So oxcarbazepine and lamotrigine ideally, because they are sodium channel and they aggravate myoclonus. And myoclonus in them are very severe. They tend to fall, they tend to hurt themselves. So you should be making very sure looking like, so sometimes those atypical absences in JME can be taken as complex focal seizures, and this medicine can be started. So make it sure you don't start this carbamazepine or sodium channel of drugs in JME patient. Yeah.
Okay, so with this we finished 3 OSCEs today. First for the late hemorrhagic disease of the newborn with an intraventricular bleed, a juvenile myoclonic epilepsy, and the third one was tuberous sclerosis. So with this, I'll stop screen sharing and we move ahead with the case presentation here. Subsequent sessions will be conducting more of OSCEs. So Dr. Sanjay, should we go ahead? Can you go ahead with the case?
Yes, please. Yes.
Shravani, you can start sharing the screen. Roughly, we'll take the case for about an hour. 15 to 20 minutes would be given for your case presentation, 15-20 minutes for the discussion and the differential diagnosis and management. Dr. Abhijit Botre and Dr. Uday Rajput will be questioning you on this case. So over to Shravani.
Good evening, everyone. Today I'm going to present a case of 2 years old male child with complaint of weakness. So my case is 2 years old male child, first by birth order, born by non-consanguineous marriage, resident of Dhanori, Pune, Hindu by religion, informant is mother who is reliable, brought by parents to hospital with complaints of frequent falls and difficulty in walking since 4 days, complaint of inability of getting up from floor since 3 days, complaint of inability to sit independently since 2 days, and complaint of reduced movements of hands as noticed by parents since 1 day. So complaint of frequent falls and difficulty in walking. Parents noticed that the child had frequent falls while walking. He started to look for support while walking and difficulty progressed to inability to walk without support. Then over the next 24 hours, weakness progressively worsened and parents noticed that the child had difficulty in getting up from the floor. Child required support from surrounding object to get up from the floor and was unable to independently from the floor. Then over the next 24 hours, parents noticed difficulty in sitting. Child used to fall sideways or backward while attempting to sit. He required support of pillows to sit. Then over the subsequent 2 days, weakness progressed and involved upper limbs. Parents noticed that the child had trouble in grasping, picking up toys along with the frequent dropping of toys. Then parents observed reduced spontaneous movements of hands. However, child was able to lift arm above the head. There was history of fever and cough 10 days ago, which lasted for 3 days, and fever was acute in onset, high grade, documented 101 to 102 degree Fahrenheit, intermittent 4 to 6 hourly, and relieved by medication. Cough was acute in onset, intermittent, non-productive, without diurnal variation, and without aggravating relieving factors. There was history of ingestion of some Ayurvedic powder since 1 month of age, which was once in a month. There was no history of altered sensorium or convulsion. There was no history of fever at onset of weakness. No history of fever, sore throat, neck swelling. There was no history of loose stools. No history of recent vaccination. No history of trauma to back. There was no history of dog bite, no history of snake bite, no history of any medication use, no history of intake of honey or canned food, no history of diurnal variation in weakness, and no history suggested that child was crying or handling.
Okay,
Uh,
go ahead.
Okay. Parents didn't notice any abnormal position of eye or movements of eyes, no history of any facial asymmetry noticed by parents, or deviation of angle of mouth, or drooling of saliva, nasal regurgitation, or nasal twang in voice, or change in voice. There was no history of excessive sweating or flushing, no history of difficulty in breathing, no history of change in bowel or bladder habits. Child continued to pass urine and stool normally. Can I proceed?
Okay, yes, Shravani, you can complete your onset duration progress.
Yes, sir. This
You are
is.
completed?
Yes, sir.
Yeah, okay, okay. So nice presentation, Shravani. Can you go back to the first slide of the
Yes.
chief complaints?
Yes, sir.
Yeah, so from the history, the child is having difficulty in walking and inability to get up from the floor and inability to sit independently. Okay, so what things comes to your mind when a child is not able to perform the routine activity? Can you just summarize what are the different causes that comes to your mind?
So frequent falls and difficulty in walking is suggestive of lower limb weakness. So this
Okay.
can be weakness can be muscular, muscle involvement or nerve involvement. So
Okay. Do you feel this is a neurological weakness or non-neurological weakness?
more, sir, further after further history we can tell whether it is muscular or neurological.
Yeah. So you have presented all the history. Go to the next slide. So what do you think? Is it a neurological weakness or is it a non-neurological weakness?
So neurological.
Okay. Why do you say this is a neurological weakness?
So considering its progression from lower limb and how is progress to upper limb progressively.
Okay. Suppose you have seen this child on a day one with a neurological weakness in the lower limb, or you say a weakness in the lower limb. Can you just enumerate few causes of pseudo paralysis? Can you tell me what is the difference between pseudo paralysis and true paralysis?
The pseudoparalysis is generally fracture, hematoma, septic arthritis.
Okay. Okay, very
So
good. So
there
you have
is
hematoma, fracture, strain. So these are like a pseudo paralysis. What do you mean by pseudo paralysis? It's a weakness is not there, but there is a difficulty in moving the limb. Okay. So whenever the child moves the limb, there is a difficulty. And what is true paralysis? Basically, there is a pure weakness. Okay. So anything else in this history that will tell you this is neurological weakness? Now your progress with the history. Okay, you said something, the problem with the sitting. What that tells you?
uh, it is progress to proximal involvement of muscle. So it is not
Okay.
localized or like only static, septic or in septic specifically it will be localized to joints or.
Okay, see, when you present your onset duration progress, the first thing that you should mention, what is the extent of the disease? Now here we have seen there is some weakness which has started in the lower limb and now it is progressing. So after lower limb, which area is involved with your history?
Trunk.
Trunk is involved. Very good. So truncal muscle weakness, you can see here the child was having difficulty to the sit. Then
Yes.
what happened? Then where it has progressed?
Then it progressed to upper limb. So
Okay.
dropping of toys and grasping, difficulty in grasping.
Okay. So now you have come to differentiate between pseudo paralysis, true paralysis, and in true paralysis, how the disease has progressed from the ascending order from lower limb to the core truncal weakness as well as the hands are involved. Now, from this history, you presented very nicely. Can you differentiate whether it is upper motor neuron weakness or lower motor neuron weakness from the history?
Yes, sir. So, all history were suggestive of like loss of tone, and there was, sir, actually for
Okay,
on
what
further
tells you there
examination,
is a loss of tone? No, we are in history. We can know in the history also whether it is upper motor neuron. Okay, can you just tell me what is the difference between upper motor neuron weakness versus lower motor neuron weakness?
yes, sir.
We are looking at broadly. Yeah.
Yes, sir. Upper motor neuron weakness, there is spasticity, then
Yes.
increase in reflexes, exaggerated reflexes, clonus will be
That is
there.
on examination. That is on examination. Okay, Shravani. So if you have a spasticity, there is an involvement of a group of a muscle. Okay. So what we are going to have? We are going to have some movements, but which are not up to the normal marks. Okay. They are not in a normal way. So if she is moving the hand, there is a stiffness in the hand, but she can hold the pen. Okay. But there is a stiffness. So there is a weakness with the quantity of the muscles are involved. So in upper motor neuron, there is a stiffness. Child can perform some task, but with the difficulty. Okay, can you just tell me what happens? We commonly ask to know the distal muscle, whether she was able to wear the sleepers or not. Have you asked that history?
Sir, actually, it
You
was
said the toys.
yes. For upper
Yeah,
limb, I asked toy grasp.
toys. So what that tells you?
Grasping was impaired, so distal weakness was there in upper limb.
Yeah, so there are two things. In upper motor neuron, what will happen when the tone is increased? Suppose child is want to grasp something, he will grasp with the stiffness, but that he is not able to hold it. The difficulty in grasping, it's upper motor neuron. What happens in lower motor neuron? As you have a quality of weakness in the muscle group is weak. When the child will hold, he cannot hold it and the object will fall from the hand. Okay, or sleepers, he is not able to hold the sleepers in the foot. Okay, in upper motor neuron, there will be difficulty in wearing the sleepers. So you have to differentiate on your history whether it is upper motor neuron and lower motor neuron. So here, what you are saying, the child is not able to hold the toy also, and there is some weakness that you have said. Child was not able to sit, okay, or get up from the sitting position. What that tells you? Which groups of muscles are required for getting up from the sitting position?
The truncal muscle, sitting position, proximal muscles, gluteus and hamstring muscles.
Which? So these are called as a which group of muscle? Flexor, extensor. Which are the group
Extensors,
muscles
hip
required?
extensors.
Yes, very good, very good. So you will require hip extensor, knee extensor, as well as dorsiflexion of the foot to get up from the chair. Okay, so when these muscles are weak, there is a weakness in lower motor neuron. Okay, so once you have this weakness, can you have any additional symptoms in upper motor neuron versus lower motor neuron? We have looked at the motor part only, motor symptoms. Can you have any other symptoms that can also come in this situation apart from motor weakness?
Sensory
Yes,
involvement,
yes, very
center
good, very good. So you may have a sensory symptoms also, which will be more in which upper or lower?
lower motor.
Upper motor neuron you will have sensory or lower motor neuron you will have sensory?
So lower motor.
Predominantly. Yes, it will be more in the lower motor neuron. So you have a specific weakness, quality of muscles has gone down. You have a weakness of getting up, which is progressed to the truncal to upper limb, as well as there is a no sensory symptoms presently. So this looks like a lower motor neuron type of weakness from your history. Now, third part of the extent, when you diagnose, analyze your history, where is the lesion? Now you have to tell us where is the lesion from your history. So lower motor neuron, if you are saying, can you just enumerate what are the parts of lower motor neuron?
Yes, sir. Starting from anterior horn cell, then nerve root, peripheral nerve,
Okay,
and neuromuscular
okay,
junction and muscle.
Very good. So just tell me the weakness from each of this part and where your patient is fitting into that.
Sir, if anterior horn cell is involved, then weakness will be purely motor. There will not be any
Okay.
sensory part. And
Okay.
mostly polio and non-polio viruses involve anterior horn
Yeah, so
because
that is the etiological diagnosis, polio and non-polio.
yes. And then this
Just
can
now
be,
polio we don't have, but which type of polio? Which are the types of polio? You know, what are the types of polio?
sir, there are symptom-wise inapparent stage and abortive stage,
Yes.
paralytic and non-paralytic.
Yeah, very good. So there are four type: inapparent, apparent, non-paralytic, and paralytic. Again, in paralytic, there are four types. One is
Yes,
spinal, bulbospinal, cranial.
bulbospinal, bulbar, yes.
Yeah. So how the spinal polio will behave? What will be the weakness?
Spinal will present as acute onset of flaccidity and
Yeah.
hypotonia or reflexia.
Okay, so it's mainly unilateral asymmetrical patchy involvement. That is very classical of the polio because few anterior horn cells are getting involved and it is in a patchy involvement. So one of the polio. Then can you go to the after anterior horn cell? What is the next thing?
Nerve root involvement.
Okay, so what is the characteristic?
So root involvement, there will be segmental or dermatomal sensory loss and myotomal involvement of muscle. So
Okay.
particularly that nerve will be affected.
Okay, nerve involvement. Okay, now root involvement, and there can be a compressive nerve root involvement, which may have a pain and sensory involvement. That you have said correctly. Okay, can you tell next part of lower motor neuron?
Nerve involvement, neuropathy.
Yes.
There
Yes,
will
neuropathy. So what are the features of neuropathy?
The neuropathy, again, loss of weakness, flaccidity, then
Okay.
reflexes will be decreased or absent.
Okay. So in history, there will be a both motor and sensory symptoms can be present in the nerve involvement. Okay. Then comes,
Neuromuscular junction.
yeah. So what is the characteristic of neuromuscular junction?
There will be fatigability and diurnal variation in weakness.
Okay. Okay. And anything important? Which muscles are affected in neuromuscular junction?
Ocular muscles.
Yeah, fast acting muscle. They are getting fatigue early. So ocular muscles are commonly involved in a neuromuscular junction. Then comes
Then it's muscle. So muscle
muscles.
myositis. So it will be purely motor and proximal weakness will be more than distal.
Yeah, so there is no sensory involvement. Mainly, predominantly proximal muscles are involved in a myopathy. So now with this description, what you have said very nicely, can you tell me where your patient is sitting into?
Sir, it will be either nerve root or nerve involvement.
Nerve involvement. Okay. So, but there are no sensory symptom in the nerve here. Okay. So, as far as this history of the extent is concerned, it is lower motor neuron type. Probably there is a anterior horn cell involvement or nerve involvement you want to say as microanatomical location. Can you tell me the next part of onset duration progress? What we do? Etiological diagnosis. So you have taken some negative history. Can you just go to that? Yeah.
Yes, sir.
Yes. So you start with that. Huh?
So first
Start
is
reading. Tell me why you are asked and what disease you are suspected in your
oh,
mind, one by one. Yeah.
first is no history of altered sensorium or convulsions. This is to
Okay.
look encephalitis, specifically acute disseminated encephalomyelitis.
Edema. Yeah.
Yeah, yes, sir. Then
And
next
any other common thing, metabolic problem where there is an encephalopathy and there is a weakness?
porphyrias.
Yes, very good. Porphyria. Can you just quickly tell me which are the drugs which aggravate the porphyrias?
So barbiturates, phenytoin.
Yes, barbiturates, sulfate drugs, and tricyclic antidepressant. So these three common groups you have to remember. Okay, go ahead. So that is not there. Next, fever at onset of weakness. Why do you ask this thing?
So this is classically seen in polio and viral myositis.
Okay, so at the peak of the fever, you get a weakness that is very characteristic of polio and myositis. Next,
Then no history of fever, sore throat, or neck swelling. This is to rule out post-diphtheric polyneuropathy.
Okay, what is the duration when post-diphtheric polyneuropathy will come after the diphtheria, or is it an
Around
acute
4 weeks.
phase?
So after
Yeah,
4
3 to
weeks.
5 weeks. After the 3 to 5 weeks of involvement. Yes. Next.
Then no history of loose stools. This is to
Okay.
rule out the enterovirus infection or specifically Campylobacter infection.
Okay. Okay. Go ahead.
And then no
Recent
history of
vaccination. Which vaccine?
recent
Which
vaccination
vaccine?
is influenza, OPV, and meningococcal conjugate vaccine.
Okay. Any other vaccine you know that can cause GBS as AEFI we report?
COVID-19 vaccine.
Okay. TD vaccine and MMR can also give rise to the GBS, like acute flaccid paralysis. GBS can come with this. So this group of vaccine you should know. Okay, that is important. And previously there was rabies vaccine, but now we are using all so that doesn't GBS. Okay, next.
The
Trauma to
history
back,
of
yes, absolutely. Yes.
the
Yes,
cord
Ram, go ahead.
injury. Yes, to
Cord
rule out the
injury.
cord injury.
Okay, what is
And
the features of cord injury?
sir, in cord injury, there will be sensory level will be present and early bladder bowel involvement will be there.
Okay, which is not
And
there in your. What are the diseases of the cord you will think of?
uh, so intramedullary, in traumatic or in general.
No, in general, in general.
So in general, compressive myelopathy is due to tumors and
Okay. And the most
but
common differential diagnosis we have in AFP,
so transverse myelitis.
transverse myelitis. Yes, very good. Transverse myelitis. Can it be a new spinal shock in your
Yes,
patient?
early stages of spinal shock can present like element.
Okay. How many days the spinal shocks remain? So it's a upper motor neuron involvement, but presenting with hypotonia and weakness. How many days it remains? Spinal shock. Okay. It's around 10 days to a week time. Okay. After that, you will get a upper motor neuron sign with spasticity and increased tone. Okay. Go ahead. Very good. What other etiological thing that comes to your mind? Yes.
No history of dog bite to
Okay.
rule out rabies.
Which
Then
type of rabies?
it's a paralytic or furious type of. So not
Not
furious,
furious,
dumb
not
or paralytic type.
dumb type of rabies. What is the diagnostic test of the rabies in a live patient?
So CSF or serum PCR.
Yes, CSF antibodies. So any detection of rising titer of antibodies is suggestive of rabies. Go ahead.
Then no history of snake bite. So this is
Okay.
specifically crate or cobra snake bite, which will lead to
Where you will
injury.
put the snake bite problem, nerve, neuromuscular junction, muscle.
It's a neuromuscular junction.
Okay, neuromuscular. So what history you have to ask specifically? So it is a ophthalmo-fascio-bulbar palsy along with anywhere on the body cellulitis. With this history, if the child comes to you, you have to think of snake bite. So ophthalmo-fascio-bulbar plus cellulitis anywhere on the body in a dire situation where history is not very clear, you have to treat the child with ASV. Okay, that is important. Very good. Next.
Then no history of intake of honey and canned food, which is for
Okay.
botulism.
Yes, go ahead.
No history of diurnal variation in weakness, again
Yeah.
for the neuromuscular junction like myasthenia gravis.
Yeah, that we have discussed. Go ahead.
The no history suggested that child is crying or handling. This is specific for myositis. There will be pain will be more.
So myositis, or it can be any other vitamin deficiency where child is crying on handling.
Scurvy, vitamin C.
Vitamin C deficiency, yes. Why there is a pain in vitamin C?
So subperiosteal hemorrhage
Yeah,
can.
very good, very good. Subperiosteal hemorrhage. So this is pseudo paralysis. Here you are going to have. Okay, so that is one of the cause you are asked. Okay, go ahead.
Then parents didn't notice any abnormal position of eye, movements of eyes, No history of facial asymmetry noticed by parents, deviation of angle of mouth, drooling of saliva, nasal regurgitation, nasal twang in voice, or change in voice. So this is to see whether cranial nerves are involved or not.
Okay, go ahead. So I think there is no other autonomic disturbances, no breathing problem, and bladder involvement. Okay, so can you just summarize your history and give just an analysis of your history?
Yes, sir.
Now put everything together and analyze it.
I would like to just interrupt. I mean, just,
Yes, yes, Dr. Abhijit.
yeah,
Yeah.
everything was taken very well. I mean, Uday has kind of got your neuroaxis very well. So now, I mean, here we're looking at a baby who's 2 years. So, for example, if somebody's adolescent, paralescent, really giving me good history and good examination, I'm really happy about doing this. I mean, she did a wonderful job. But what I would like to see from you, as always we say as a pediatrician, is like act of taking history. I mean, that's how, we should kind of unfold case in front of us. So what you kind of told us is right. I mean, 4 days history. I mean, not able to walk first, then not able to sit, not able to kind of put the things in hands, and now she's like kind of there. So what I would really emphasize, being a student or being, somebody who's examiner, what I would, for example, in patient of CP, what I'll say, this patient is previously this. So as we say, little neurology, little kind of little glamour to the history. So this was 2 year girl who was absolutely well before. She used to kind of run, jump. Not jump, I would say run, could, go upstairs, downstairs. And she was doing all these things. Then she had fever and all this and whatever. So that you put in past history, which is absolutely okay. Then had frequent falls, what we kind of delineate as UMN and LMN. So UMN will probably have the tiptoeing and falls and kind of seasoning of the gait, which you can ask, in on inquiry, or you, may kind of put this thing as negative. Then you kind of put it really nice. I mean, cascade of the events where it started with from probably foot, then to knee, and then to the hips. But on history, we can definitely again get into the power of the illness as well. So, she was, so definitely what we know is not able to walk, not able to get up. So that makes the anti-gravity muscle weak. But then what she was doing currently, was she able to move her legs around the bed? Was she able to still kick? How she used to kind of, was she able to roll over? Was she able to ambulate to some distance? Because that gives me little kind of clue towards what are the involvement of the history. So it's like kind of a very, pit flock, like, floppy infant, like just no neck move, no leg movements, with no trunk movements, or was she able to roll over, take the things from the like back, close to her thing. And you, as you rightly said, she has some weakness in the hands, so the things would fall off. But then a slide thing, so you can easily ask, was she able to break the chapati? Was she able to feed herself? How the things are? Was she able to kind of play mobile and all these things, which will give me little kind of clue to the, or given to the, taken to the keyboard. Would you just put the keys? So that will give me, 3, 4, or whatever kind of power. Upper limb, you said, she could get overhead abduction. Here again, I would say how the parents were, carrying the baby. So there I would get some kind of a hint towards the neck muscle weakness, trunk weakness. So was pull to sit maneuver was possible? Was she able to sit? As you said, she was able to sit with pillows across her and all these things, which again tell me, okay, there is lots of truncal movements, involvement. But turning over on her own, taking the object with her and this thing. So one more classical thing what we get in GBS is like, along with that, do you get a sensory symptom or you don't get sensory symptom? And if some sensory symptom we get, what kind of sensory symptom is it?
Yes, the sensory involvement can be there, like paresthesia.
Typical. So if I'm saying it's kind of your motor neuropathy, but still you can get a neuro, kind of some sensory symptom. And what is that sensory symptom is like?
Paresthesia.
So can you move GBS patient on your own, or can you just kind of did kind of some, while examination, what happens to him? Does that patient wins or doesn't wins?
Sure, yes.
Yeah, so there is lots of pain while movement, leg movements. That is typically what, because we dictum is like your roots will pain and your nerves will tingle. So when it's a radiculopathy, so lots of pain you get along the movements, because the moment you stretch, so along this, so that's the reason your SLR will be positive in GPS. So you kind of tend to stretch the leg, so there is a pain, which is not really a sensory, but it's kind of a stretching of your nerve, radicals. And your, this thing. Post that, you said the things were right good. By localization, you put the things right across. I would first go on localization. I would second go on complication, and third go on etiology, which is still okay. The things were absolutely put in the right way. But again, 2 year baby, I would positively ask, how it was the cough? What was the timbre of the voice? Was she able to, if 2 years baby breastfeeding, what was the span that she would breastfeed? Was she leaving in between? Was she taking too frequent feeds? So that would kind of certainly give me some signs of like my verbal weakness, some kind of this thing, because this is very obvious when you don't have anything. So this is just to add on and kind of go further. So just kind of sharpen your history, but the things were very well taken. Yeah.
Yeah, I think just to add to that paresthesia, can you give the explanation why the child is having paresthesias in GBS?
No, it's not paresthesia. It's like kind of a root pain. So when you have the extension
yeah.
of the root.
Yeah, root pain. So, yeah, Shravani, if you have paresthesia, tingling numbness, so that is paresthesia. Basically, it's a perception of a sense of stimulus. Why you get in a GBS? Can you explain pathophysiologically why these symptoms are there?
So due to
So, as
sensory,
Dr. Abhijit said, yeah, why you get these symptoms? In your patient, it is not there. You're not told in history. But if you get it, what is the pathophysiology? Because you, as a resident, you have to explain every symptom and a sign, why they are present pathophysiologically. So you have a large myelinated fibers and small myelinated
yes, sir.
fibers.
So large myelinated fibers generally inhibit small fibers. So if there is a
Wearing a shirt or a dress, you can't feel it because your small fibers are continuously firing, but your large fibers are suppressing them. You have to remember that. In GBS, when there is a demyelination, destruction of the large fiber happens, the small fibers creep on firing. So this fire gives rise to tingling and numbness. So to have a tingling and numbness, it suggests the large fibers are still getting destroyed. So it is a destruction process that is going on. So you have to keep in mind when you have tingling numbness, there is a destruction. Versus there is one more theory that is called as a this destruction is an active process that is going on. So this is not a good symptom. You have to think the child is progressing. And how the Dr. Abhijit has correctly said, the weakness, simple shoulder weakness will tell you it has come up to C5. So suddenly it may go to C2, C3, and there will be a weakness, bulbar and a respiratory involvement. So this important history, you have to tell about the sensory symptoms also. I think we can just summarize it and we can go quickly to the next history points. Yes, Dr. Abhijit, anything you want to add?
No. And this is a recurrence. So usually you have kind
Yeah.
of channelopathies and hypokalemic and hyperkalemic, but not to
Yeah.
this stage. But again, she was doing absolutely okay. So I would probably would like to add into it because
Yeah.
lots of PGs are hearing it. So mind you, well, I mean, the common things first and then uncommon things. Don't keep on putting uncommon thing and kind of put the examiner into kind of this thing where your basics are not right and you are just putting the uncommon things first. Yeah.
Yeah. Go ahead. Go ahead with the history. Yeah.
One question
Summarize
to
and
Truth and Dr. Abhijit. Here we are localizing it to a lower motor neuron. Here it's just a 2-year-old child, so he's not able to give us sensory symptoms. So can still transverse myelitis be considered because we are not going to? He's not having bladder bowel control at 2 years. He's not going to vocalize. So why are we just? We are just talking about lower motor neuron, right? So could it be this one of them that the spinal shock stage of transverse myelitis also can it be considered as?
Yeah,
yeah,
definitely. I
it can
mean,
be considered.
Mm.
Yeah.
Yeah. So myelitis is definitely one of your differentials because what happens in this thing is you may have because your hands is you are kind of lower cervical and thoracic and lower, but then you will have some abdominal weakness. That's the reason. I mean, you have to have asked this kind of a turning over and all these things.
Yes. Go ahead, Shravani.
Your screen sharing has stopped.
Yes.
yes, can I proceed?
Yes,
Yeah.
please. Go ahead.
So past history, there was no history of admission or no history of similar complaints in past.
Which disease you will think of similar complaint, suppose in the past, bigger child, quickly.
So episodic, if there is episodic illness, then it can be periodic paralysis.
Yes, yes,
Myasthenia gravis if older child is dead.
yes. And can GBS have a recurrence,
Yes, sir.
relapse? Yeah.
Yes,
What is the percentage?
4%.
How many percent of cases?
4 to 5%.
Okay, it's very rare. Okay, go ahead.
Then
Birth
birth
history.
history.
If
There
if
was
there is anything significant, you just highlight, or we can go ahead with the next
That
part.
makes sense. Yeah,
birth
exactly. So you
history was
can.
not significant.
Okay.
Then developmental history. Development is appropriate for age. No
ठीक है.
developmental delay. Then immunization history. It is complete till date according to national immunization schedule.
So we have seen which vaccines are highlighted for the acute flaccid paralysis. Next.
Yes. Then nutrition history, according to 24 hours recall method, child is averagely nourished.
ठीक है.
Then family history, no history of similar complaints, episodic weakness, consanguinity, or early deaths in family. So it was
Okay.
actually not significant.
If we have the family history of those kind of weakness, so what are your suspicions are like?
So congenital myopathies or episodic hypokalamic periodic paralysis.
Okay, anything else? So will myopathy will present now with normal baby?
No, sir. It will be a chronic and
So
gradual.
which kind of disorder will come in your mind? So all
Muscular
inherited neuropathy, so
dystrophy.
Charcot-Maries and all these things. And one of the recurrences, like of course, I mean, we've spoken about is not kind of a neural, neural pathy, but sometimes recurrent rhabdomyolysis again can come with kind of a flaccid weakness, which you can so CPD deficiency and all these things you should keep in mind for sure.
Okay. Then socio-economic history, family is nuclear family. Then water supply is tap water using water filter, safe drinking water, and belongs to upper middle class according to modified Kupuswamy scale.
ठीक है. See, whenever you are highlighting the socioeconomic history, the purpose of socioeconomic history is also knowledge, attitude, and practices. See, this is a chronic condition where the child is going to suffer with some psychological trauma. So you have to also highlight what is the attitude, knowledge, and practices of the parent, so they can able to take care of the child properly. Okay, because there is a lot of psychological stress involved in this case. Okay, go ahead.
So,
Yes.
to summarize, after history, this is 2 years old male, developmentally normal, completely immunized according to National Immunization Schedule, with history of acute respiratory tract infection 10 days ago, with acute onset progressive quadriparesis, bilateral symmetrical weakness of both lower limb, ascended to upper limb, with distal involvement more than proximal, without complication, without bulbar respiratory bowel bladder and autonomic involvement with normal cranial nerves is a case of acute flaccid paralysis with probable etiology of first will be GPS, second is transverse maladies, and third one is heavy metal poisoning.
Okay. Why do you think of heavy metal poisoning in this child?
So there was
Have you?
history. Yes,
Yes.
sir, there was history of some Ayurvedic powder injection since
Okay.
1 month of age and every month. So,
Okay. So which heavy metal you are thinking to cause presentation like this?
so mostly lead, arsenic.
Lead and arsenic. Okay. ठीक
And sir,
है. Go ahead.
actually, there were specifically history of Suvarna Bhasma, which was gold
Yeah.
containing powder.
Yeah. I think you have mentioned that in your history since the 1 month child is consuming. Accepted. Go ahead.
Yeah, and I
Go to
would
the
put a
exam.
probably without obvious, historical history of weakness, because on examination you may find it. So which is still okay. Yeah.
Go to the examination.
So general examination, general appearance, child is conscious, alert, lying in bed with reduced spontaneous movements of hands and leg. Anthropometry wise, weight is 3rd to 10th centile, height is 58 to 75th centile, head circumference and mid upper arm circumference normal. Then vitals, temperature is afebrile, pulse rate is 102 per minute, normal volume, normal rhythm in right radial artery. Respiratory rate is normal 22 per minute without distress. Blood pressure is 92/60, which is 58 to 90th centile, right hand supine position. Saturation is normal and no.
Yeah. So considering this is a acute flaccid paralysis and one of the differential is GBS, what abnormality you will see in the vitals?
So in the pulse rate, there can be tachycardia, pressure, blood pressure changes. Then respiratory paradoxical movement can be there. For
So
that.
there can be tachycardia, bradycardia. There can be hypertension. There can be hypotension. Which week after presentation you will have all these changes?
First week, sir.
After first week. So they are not there in the first week. Okay, they are after first week. You will get all the autonomic changes in a child with the GBS. Go ahead.
And what is the reason of this dysautonomia?
So involvement of sympathetic and parasympathetic ganglia.
Yeah.
Then head-to-toe examination, there was no significant finding in head-to-toe examination.
Okay.
Skull was normal.
I think if everything is normal, go to the central nervous system examination. We'll concentrate on that. Yeah.
Here you should mention about the palpable nerves.
Yes, sir.
Because one of
No
these things, so
peripheral.
no neurotransmitters markers and palpable nerves. So those kind of for CNS thing you have to kind of mention pass a mention. Of course, though it is acute case, but still to kind of a complete examination. Yeah.
The child is conscious, alert. Speech and language is appropriate for age. Recognizes mother. On cranial nerves, cranial nerve examination is normal. Second nerve fixes and follows toys. Pupil is reactive to light. Then for third, fourth, sixth nerve,
For
spine.
just a minute, Shravani. For every nerve, you tell us some disease, at least one or two, which will present with a element type of thing and cranial nerve affection. Can you get second nerve affected with some cord involvement? Can you think of some disease where there is a optic neuritis and myelitis both together?
Yes, sir.
I
Sir,
told you.
neuromyelitis optica and Adam also optic
Yeah,
neuritis.
absolutely. Yes. So this is normal. Third, fourth, fifth.
Sir, ptosis in myasthenia gravis, OP poisoning, and snake bite also. Third.
And and now this is a GBS case, so you should tell that diagnosis.
Yes, cranial nerve in the third nerve can involve GPS also. Cranial nerve.
What is that called as?
Miller-Fisher syndrome.
Miller-Fisher variant. So what are the triad of Miller-Fisher variant?
So ophthalmoplegia, ataxia, and areflexia.
Very good. Go ahead.
Then fifth, jaw movements are normal. Sixth, facial asymmetry, facial asymmetry, no deviation of angle of mouth, can close eyes tightly.
Can you get a facial nerve affection in GBS?
Yes, sir.
Yes. Which type of? Upper or lower?
Lower.
Lower. Suppose if you have bilateral lower facial nerve involvement versus bilateral upper facial nerve involvement, how will you differentiate?
So generally in lower facial involvement, other symptoms like test sensation, then hyperacusis, this can be there. And in UMN, it will be areflexia involvement, hyperreflexia.
UMM is above the pons. The problem is above the pons. So if you get bilateral facial nerve involvement, there is a problem above the pons. So what we see, the jaw jerk. If jaw jerk is preserved, and I told you initially, if you have bilateral upper motor nerve involvement, UMN lesion of facial, you will have again some function present, but not in a proper way. While in lower motor neuron, the quality is gone down and there is a absent reflexes. Okay, so this is very simple to remember. Okay, because sometimes if there is a bilateral involvement, it gets very difficult to know whether it is unilateral upper motor or lower motor neuron. In lower motor neuron, always remember emotional fibers are affected. So somebody cracks a joke in UMN, bilateral UMN, child may laugh a little bit because there is something is preserved. While in element, it will be like a face-like face, mask-like face. So he will not have any emotional activity in a bilateral lower motor nerve. In bilateral upper motor nerve, you will have preservation of the reflexes, glabellar tap, your jaw jerk will be present with some emotional fibers spared in that group. So you have to differentiate all this thing. Simple history, you can ask whether the child is able to close the eye when he's sleeping or not. It will tell you upper motor neuron. Go ahead.
Then eighth nerve respond to calling. Ninth and tenth, uvula is central, swallowing is normal, gag reflex is present, no nasal regurgitation and normal voice.
What you will
Then,
see at the uvula in the gag?
upper elevation of pharynx in the gag.
So you will see the movement of the pharynx. Okay, uvula. So they will be weak if you are having lower motor neuron. Okay, bulbar involvement. So this is very important. You have to tell. Don't say I will look at the deviation. Okay, it is bilateral involvement in your case. Okay, go ahead.
Then 11th nerve, normal head and neck movements. 12th nerve, tongue is midline, no tongue deviation.
And anything else you want to tell in tongue?
Tongue fasciculation or waste.
Fasciculation. You have to tell that also in the examination. How you will demonstrate the fasciculation in the tongue? Suppose I ask you to demonstrate in a child fasciculation in a tongue. What thing you will ask the child to do?
So protrude tongue after tongue protrude.
Exactly. You don't have to say protrude. Okay, the fasciculations are always seen when the tongue is inside the mouth. So just you have to ask the open the mouth and the tongue has to be in the mouth. Don't ask to protrude. That is not a correct way. Okay, remember this thing. Go ahead. Motor examination.
Motor examination.
So
Muscle
what is
bulk is
your surrogate marker for single breath test? Because for adult you do a GBS, you do a single breath test, isn't it? So you ask them to count and see for the tidal volume. So what is your kind of a surrogate marker for a single breath test in a 2-year boy, 2-year boy or 2-year girl? Or how you are pretty sure that all bulbar things are absolutely okay. So your examination seems to be okay. And what Dr. Udayas again said is you get facial diplegia. What do you need to say? Because fiber of the orbicularis oculi are get paralyzed. So basically ask him to close the eyes and try to open it against the resistance. So many times you have bilateral facial. So your facial deviations, all these things may not happen. You will just have this facial kind of a orbicularis oculi weakness. So what is surrogate marker for your single breath test? So the cry, is he taking the kind of a, I mean, gaps in the cry and the, if at all, I mean, of course, he's like just 2 word sentences he's speaking, but how long his sentences like? Is he taking any kind of a pause in between? So, माझं नाव अभिजित आहे. This, if at all, he's saying he's taking between, I mean, gaps, I mean, some kind of a lapses between his talk. Definitely, that is your surrogate marker for your single breath test because those kids who are not able to count till 20 will be very difficult. So you just need to keep on talking to them or ask them. I mean, like probably if they're crying, you just see when he gasped for his breath.
Anything else you will look in the examination? Suppose this is a small baby, 2-year-old. Okay, very difficult. Okay, so anything that you can see objectively for the respiratory muscle weakness, what test you will do?
paradoxical movement of.
So how? What is that? How you will do it?
So normally during inspiration, there will be outward movement, but if
That
chest
is
and
observation. But will you do any maneuvers to look at
Objectively, I
this
will
thing?
say.
Diaphragmatic weakness and intercostal muscle weakness. So you have to do the splinting.
thinking of diaphragms.
Yeah, so splinting of diaphragm on the this side and then splinting of the respiratory muscle, intercostal muscle. This will objectively you will come to know whether there is a weakness or not. Okay, go ahead. Motor examination.
So motor examination, muscle bulk is normal, tone is hypotonia in all 4 limbs. Then power, so upper limb, shoulder and elbow 3/5, wrist and grip is 2/5. Then lower limb, power is 2/5 in all lower limb, neck, no neck drop, and trunk is not able to sit.
Okay.
So would you see it exactly 3 or more than 3? Go back to the charting.
So 3, upper limb, shoulder, and he was able to.
Why 3? Why not 4? And why not 5?
Sorry, sir.
Why 3? Why not 4? And why not 5? Because you said he could take the object from the, I mean, he could raise the hand above the
There
head,
was
right?
some kind of weakness, not against resistance, but slightly he was able to elevate and take.
Pardon me? So here your examination things come, right? So you are kind of a, shoulder flexors, extensors, abductor, adductor. So which muscles are kind of you found more weak? We didn't get into that details.
The extension was there, so
Mhm.
but all muscles were equally affected, not specific.
So you have some shoulder weakness as well, isn't it?
Yes.
Along with the on examination.
Yes.
Okay. And how did you demonstrate the neck drop or head lag?
Sir, lying on the edge of the bed, so there was no neck drop. If
So he could hold his neck.
he was able to hold his neck. Yes.
Okay. Okay. Any other manuals you can do to see the head lag? Yeah, I think somebody answered. Pull to sit. So you have to do a pull to sit manual. And while pull to sit, you see whether the neck is coming in anticipation or just floppy. I mean, kind of flop. I mean, kind of a drops. I mean, on your shoulders. Yeah. Next.
The reflexes, superficial reflexes, conjunctival, corneal, abdominal, and cremastic were present, but plantar was mute. And deep reflexes, all were absent, sir. Biceps, triceps, supinator, knee, and ankle.
Okay, go ahead. I will look for the coordination.
Sir, coordination, it was not possible.
Okay, why? You are correct.
Actually, upper limb weakness was there. So in distal weakness, so finger nose was also not possible, and gait examination was also.
So you should require 3 and above power to say comment on the coordination. You cannot comment when you are having 2 or 3. Okay, it should be 3 and above. So to comment on a coordination. Okay, that is how you should answer in exam. Yeah. Okay, go ahead. Okay, I
You
think
said the
everything
baby
is
was
normal.
hypotonic. Yeah. You said the baby was hypotonic. So what are the kind of thing you made a conclusion that baby was hypotonic? What are your objective? Inspection, palpation, and maneuvers to kind of
Now,
assess the hypotonia.
inspection first we see the posture. So there was reduced movements on inspection. Then palpation we see the muscle flabbiness, and
Yeah.
for we see the passive movements of limbs at each joint. So if there is increased range of movements, and if we can move more easily, then there is a decrease in the torque.
Any maneuvers will do rather than passive movements. So you flex the knee and you flex the hip and just release. They'll just go like plopping. You just kind
Shaking
of
of
put the hand and just put it down. See, it's how it's kind of going. So those are rolling of these things, which is again one of the things you can show that you can have the increased range of movement again, which comes in your couple of maneuvers and kind of a range of.
So passive, basically shaking method as well as rolling method you can use to demonstrate. Okay, better if you can put a picture of the patient here. Okay, so it becomes easy for the examination point of view. Yes, go ahead.
Then spine examination normal, and no any finding related to meningeal irritation. Then other systemic examination, it was not significant. There's equal bilateral, chest expansion adequate, cardiac abdomen normal, and bladder was not palpable.
Yeah, very good. I think
Then
she has
after,
positively added that
can I
point, bladder
proceed?
not palpable. So it's very important. You should add that point, bladder whether palpable or not on per abdomen exam. Yes, diagnosis.
Yes, sir. So this is case of 2 years old. 2 years old male child, developmentally normal, completely immunized.
I think there is some
Learning
internet issue.
with distal involvement more than proximal, without complication like without bulbar respiratory.
You muted yourself, Shravan. I think you have to unmute yourself.
You are mute and your range is not so good.
I think your voice is not getting. Can you just read the diagnosis again, final? Yeah, you can show us the investigation. No issues. You
Just
can just.
muted herself also.
Unmute Shravani.
Unmute Shravani.
Hello.
Ah.
Hello.
Yes,
Unmute
Shravani.
yourself. Yes.
So 2 years old male, developmentally normal, completely immunized according to national immunization schedule, with history of acute respiratory tract infection 10 days ago, presented with acute onset progressive quadriparesis, bilateral symmetrical weakness of both lower limb, ascended to upper limb, with distal involvement more than proximal, without complication, without bulbar respiratory, bowel, bladder, and autonomic involvement, with hypotonia and areflexia, with normal cranial nerves, is a case of acute flaccid paralysis with localization, lower motor neuron, peripheral nerve involvement, with probable etiology. First is GBS, transverse myelitis, and heavy metal poisoning.
Okay, good. I think can you just go to the investigations?
Yes, sir. So first complete blood count, it was hemoglobin was 10.7, total count 11,000 and platelet 475. Then serum electrolyte sodium potassium within normal range. CSF routine was suggestive of albuminocytological dissociation with protein being 181 milligram per dl, and total cell count was 4 to 5 cells.
Okay.
CSF culture biofire negative and antiganglioside antibodies were negative. MRI spine was normal. This is NCV report suggesting.
So would you consider a heavy metal at this point, or any which are the on examination, any of the things which are kind of against your heavy metal of intoxication?
No, sir, other symptoms were not there any.
Like, so what is the weakness or what is the paralysis in hematotoxins?
So mostly it is peripheral neuropathy.
So usually multiple, I mean, mononeuritis multiplex. So they'll come with one of the other nerves, like foot drop and all these things. It won't come
Yes.
with such a kind of florid presentation within 3 to 5 days. Again, that is one of the thing which is little away. Yeah.
Yes.
And one more thing, I mean, one of the investigation you missed. What is that? The most important investigation?
Sir, antibody, it was negative.
This is AFP case, na Shravani?
Yeah,
So
exactly. So
what
that
you
will be
will
kind
do?
of a, exactly.
First thing you will collect.
Yeah. First is reporting and collection and sending the sample. That is the most important thing. You did
Stool
so
sample.
good, but some kind
Yes.
of a, exactly. Yeah.
Somebody has mentioned. How many stool sample you will collect?
So 2 stool sample, 24 hours apart, generally within 14 days of onset of paralysis.
Why do you collect 2 stool samples?
So generally we derived the wild versus vaccine associated. So
No, but why specifically 2 stool sample, 24 to 48 hours apart? So basically you have intermittent shading of the virus, polio virus. So that's why we collect 2 samples. If 2 are inconclusive, we collect one more at the day 60 of illness. Okay. So that is also collected. Okay. If the baby is not passing stool, how will you collect the stool? Is given in national guidelines.
generally no laxative should be used.
So how will you collect? Okay, you read it. It's a homework for you. Okay. It's given in AFP guidelines how to collect the stool if baby has not passed the stool. Okay, yeah. So which investigation you will do first, MRI or neuroconduction? You have done both here, I think. So given a choice, you want to do one.
The MRI is generally done to rule out spinal cord involvement, and NCV is for demyelination.
MRI. You have history, you have examination now.
So NCV.
NCV, because there is no sensory level as such, there is no bladder involvement. Okay, so considering the cost benefit ratio also, I think NCV could have been done first in this child given option. Okay, yes.
What
Go
we
ahead.
will see in MRI of the GBS patient?
Hmm.
So MRI.
This is the most sensitive test for the, I mean, if you did a CS, I mean, MRI, and what kind of MRI will do?
So MRI T2 hyperintensity.
Will you do a plain MRI? Would you do contrast MRI? If yes, why? If you know why.
Contrast.
What MRI was done in your patient? Plain with contrast?
Contrast.
Okay. So usually what you'll see in GBS, you'll get crude enhancement, and that is one of the specific and kind of a sign for a GBS where you have an otherwise, and if, I mean, this patient would have had protein of 18, sugar of 76, and 100 cells. How you would have investigated it?
So it will be like meningitis case or something to CSF and CSF culture.
Before that? So is it meningitis or something else? Because see, I mean, whatever you kind of mentioned is your UMN and upper motor things were all okay. And sensorium was fine. There's no deficits, nothing, no cranial nerve. So looking for any infection, myelitis. So probably some infective myelitis. And what are the, I mean, kind of organism which can cause acute myelitis?
Acute myelitis generally is a post-infectious. It is a acute transfer.
No, the virus itself can cause myelitis, aren't they? So polio is which kind of virus?
RNA.
Yeah, but category. So is non-polio enteric viruses, you have Chandipura, you have a couple of other things which can come as myelitis. So when you have cellular pleocytic response, that's the reason sometimes for albuminous cytological you do it later, but mainly, I mean, dictum wise, if you do it early, and if you get cellular response, you need not to have albuminous cytological dissociation. So if you have cellular response, definitely a viral culture should have been little kind of on the urge, and giving IVIG would be last, and I mean will be considered later, and you should do an imaging to know whether there's a myelitis element there is or not. So would you get so this 4 days illness? Would you, so if at all your NC becomes normal, would you still call it a GBS? What parameters you'll see on the, of course, this is little kind of a, because I mean, you guys are DNB examiner, I mean, exam going. So definitely I would need to ask because this will come under one of the asking one of the tricky question. So if at all your NCV, so what things you look, which parameters you look in early GBS, or if at all your NCV comes normal, so what would be your interpretation? So now this CSF with MRI showing some coordinate, I mean, like nerve enhancement and your NCV is, I mean, normal.
Sir, symptom wise, if it is fitting in like Brighton criteria and acute onset, then it
So
can be.
ideally, yeah. So many centers may not do your H reflex, which is first thing to go. Yeah, F wave, which will be dispersed and maybe
Yeah.
absent and inconsistent. Those are the early GBS findings. So that you should specifically ask for, because many system, I mean, 2-year boy, you get different simulator and all this, and will be little technically difficult. And later what you get is a delayed conduction velocities and kind of a conduction blocks, and your amplitude, which is reduced. Yeah.
And
Dr.
clinically
Abhijit,
also, we have this Asber's criteria is also there. Okay, when you have any doubts like this, you should use Asber's criteria, which says 3 progressive weakness, symmetrical weakness, and areflexia, which is must for the diagnosis of GBS. Okay, yes, go ahead.
Just one question, Dr.
Can
Abhijit, what you were saying about the NCV report, can, even if the nerve conduction is normal, this wave can give us idea about early GBS.
Yeah. This can be, this can be positively asked because many centers may not do it. So, Shravani, I'm giving one more scenario. This patient has global developmental delay. So this patient with like kind of a consanguineous marriage, some global developmental delay, some motor delay, and come with this kind of presentation with some kind of a, some mild encephalopathy, little sleeping more, and now he got better with your treatment. So what will be your one of the differentials?
But if consanguinity, then SMA can be there. Sir.
So I said coming with the encephalopathy. So you consider IEM one of the thing which is like mitochondrial, because these and all these things may can have you peripheral neuropathy. So definitely you need to know. So yeah, CSF lactate should be one of the investigations of kind of a which is needed in this kind of patients. Yeah, very good. Somebody said already mitochondrial one. Yeah, you can go ahead with the treatment. And which antibodies will do?
The GM1 and GQ1.
No, are they IgG subset or IgM subset?
IgM.
IgG subset. Because that is at times, I mean, kind of a false thing which would order. You need to always ask, I mean, ask for IgG because they cross blood-brain barrier and they kind of attack your myelin sheath. Yeah.
So Abhijit, just one question: are anti-congestant antibodies required for everybody? And
No,
what
not really, not really. A typical patient, so as even Dr. Uday will tell, I mean, I kind of agree to it. So your classical progression, your NCV showing these things. So there's, so if you get pleocytosis, some subtle changes on your MRI, then you kind of need to be addressed to them.
I think it's more specifically for if you get a variant like Miller-Fisher variant, in that you can have this thing, because the differential diagnosis will change with that presentation. That's why sometimes we do that.
So basically for a
And one more historical thing. So we all know, I mean, usually GBS comes in kind of, batches. So we know there is kind of a couple of GBS coming in the hospital from that particular territory, which is again one of the kind of a clue that is dealing with a GB syndrome rather than anything else. Yeah.
Yes, go ahead, Shravani. In management, quickly.
So child was admitted in PICU for further management. Considering NCV report, child started on IVIC 2 gram per kg over 2 days. Child monitored for respiratory involvement, use of accessory muscle, monitoring for swallowing dysfunction, monitoring done for autonomic involvement, bladder bowel changes, and considering chronic history of consumption of that Ayurvedic powder, child evaluated for heavy metal poisoning. So this was his report.
Was anything significant or?
No, sir, actually, other metals were not detected, and there is no specific test for gold level. So, and gold in this neuropathy is very known, but cumulative dose of gold can be calculated. Serum gold level is not available in India. So, this
And
was.
what is your, sorry, what is the surrogate marker if it's not gold? It would respond to you to a treatment. Usually gold will kind of linger over. It may not kind of get kind of eliminated from body very easily.
Anything else you will add to the general management of this patient? Can you go back to the first slide? The first on the, yeah. So you have very nicely said everything you have monitored and this thing. What are the two important things that you will add to this as a general management of a child with GBS?
The physiotherapy.
Yes, very good. So physiotherapy, psychological support, and nutrition. These are the things you should always mention when you are presenting the case and the management of the GBS. These are very important. Okay. Uh, what is the other option for IVIG?
Plasmapheresis.
Okay. What are the contraindication for plasmapheresis? So any infant or a child is having dysautonomia or a child with sepsis is a contraindication for plasmapheresis. We consider for the older children. Okay. What is the poor outcome markers of GBS? Poor prognostic markers?
The axonal variant has poor recovery.
Okay.
The respiratory involvement, rapid progression,
Yes, very
pulmonary
good.
involvement,
And anything else?
ventilatory support.
Yes, prolonged ventilatory support, infant as well as autonomic disturbances. These are the poor prognostic marker in the case of GBS. Okay, I think, yes. Anything, Dr. Abhijit, you want to
So
add?
yeah, so you give 2 gram per kg over 2 days. So what are the kind of things you anticipate with this IVIG dose? Or what are the side effect of giving? We feel is like very non-specific kind of medicine to give, isn't it? So no side effect observed. So what are the known side effect of IVIG?
The hemolytic anemia, then blood pressure fluctuation,
Common come first.
thrombosis, septic meningitis,
Very good.
anaphylaxis can be
Allergic reaction, anaphylaxis, I mean aseptic meningitis. What else?
thrombosis, hemolytic anemia.
Very good. So thrombosis is very well known complication. So volume overload and all these things. So you have to be a little cautious giving this. So I would like to know what happened to this patient. So I mean, on day 4 of his got admitted, and then he was kind of with you and you given IVIG. Was he worsened? Was he improved? And how? What was the course?
So he improved. Now he is able to. I mean, weakness is improving overall. So his physiotherapy is going on. So not still not able to walk completely, but without support. If we ask to call his mother, then he can go with holding furniture. So at least weakness is.
What is treatment related fluctuations in GBS patient?
Yes, treatment related fluctuation is after transient improvement, there can be progressive worsening of symptoms. So generally within 2 months, it
And what is the
can.
treatment of it?
Sorry, sir.
What is the treatment of for this?
Sir, we can repeat IVIG, but
So we
if
can
it
wait and
is
watch. If
going
at all
more
symptoms are
than
worsening, we need to give IVIG. Now, I mean, you being a DNB, I mean, exam going student, I would definitely would like to know how you would counsel this patient in any language you're comfortable with. So
in
crisp, good 5-7 lines about how the things happen, what is happening, and what is my kind of prognosis.
so I will first explain key what is GPS.
You
So
explain. I am the parent.
okay, so your child is suffering from a disease which is autoimmune, in which our cells act against our own body. So this is progressive weakness. It's started with lower limb, and it can recover first of all. So I will reassure first. So and explain how we investigated and how physiotherapy should be continued, and improvement can occur.
Okay. What is the mechanism of action of IVIG? Why we give IVIG?
So it prevents FC mediated opsonization. So
So
whatever
those are for which
activity,
antibodies we are looking at? So basically,
ganglioside.
those are for circulating antibodies we block.
Yes.
The antibody is already attached to the myelin sheath and neuron. What will happen with them? So sometimes you will have kind of a increase in symptom in spite of giving IVIG. So always in kind of your counseling, you should always say giving IVIG may not kind of halt your progress because they have kind of a plateau, I mean kind of a I mean, kind of ascent, plateau, and then recovery. Of course, not all patients will kind of follow that, but IVIG may not sometimes kind of recover or get them better in like a magical wand. So they may tend to get kind of a symptom even after giving IVIG. That's the reason IVIG we are giving to kind of stopping the circulating antibodies. The antibodies which are there already kind of will create some kind of a weakness, and we have to wait and watch, and we have to monitor this patient mainly.
Yeah, I think Dr. Abhijit has asked very important question about counseling, because for MD as well as DNB, there are special marks for communication skill in the final exam. I just wanted to tell there is one Kalamazoo consensus statement, Kalamazoo scale, how to counsel the relatives. There are 7 points. Okay, so every postgraduate can go through that and make a habit of counseling every patient in your day-to-day ward or PICU thing according to Kalamazoo. You will have very good grip of counseling. Okay. Yeah.
And when will you give her next vaccine, this patient?
The IVIG is given, so at least minimum 8 months to 11 months we should wait for live attenuation.
You will give, right? This is only for live attenuation. Only MMR and chickenpox if at all, right? You can give.
Yeah.
Okay.
And as Dr. Uday even has said, so couple of things is like your kind of this chronic disorder, the nutrition, physiotherapy, handling them, because many times what happens, they kind of tend to walk and buckle their knees, buckle their ankles and tend to fall and all these things. There's lots of muscle wasting. So good high proteinaceous diet and good physiotherapy and graded kind of weight bearing is the key to their kind of improvement and kind of getting them better.
Yes, so both of you want to ask any more questions?
Yeah, I think very nicely Shravani has presented. Okay, she has prepared very well under Dr. Sagar, and she has been coached very well for all the questions. Okay, nice presentation, Dr. Shravani. Okay.
Thank you, sir. Thank you,
It was
sir.
a nice presentation. All the best, Shani, for your future.
Thank you,
Well,
sir.
yeah.
Yes, so a vote of thanks from me. Shravani, very well prepared. Could answer all the questions. Sagar, thank you. And very good cross-examination, practical points by Dr. Uday Rajput. Ekdam basic se advanced tak. And icing on the cake, cherry on the top is Dr. Abhijit with excellent neuro inputs. I would also like to thank the Maha IP for providing this platform for case discussion, which will be held every once a month on Thursdays. And I would want to thank the IP office bearers, Dr. Sanjeev Joshi sir, who's the president, and Dr. Renu Buralkar, who's the secretary for Maha IP this time, and Dr. Sanjay, who is the scientific coordinator for the Maha IP session. So
Thank you, Shishira. Good point.
and Shravani, all the very best to you. You
Thank
really
you, ma'am.
did good job. Absolutely stress free you were, and अच्छे से बैटिंग किया पूरा. So, thank you everybody.
Thank you.
I
Thank
think
you. Thank you so much.
I think this, yeah, I think we can.
Thank you for
yes,
giving
I
us the
mean,
opportunity to present the case.
Yes, Sagar, sir. Yeah, this was really nice. I mean, you mentored her very well.
No, she's
And
a quite
Dr.
bright
Uday, I mean,
girl.
like perfectly asked question. I mean, exactly. I mean, we can see teacher in him.
Nahi, Baba. She's a bright girl.
Yeah.
Thank you.
Yeah.
Thank you. Thank you so much. Yeah.
Yes.
Okay,
Thank
bye.
you, sir. Thank you, ma'am.
Good night. Bye.